This is presentation number 21. GIT will deal with secondary malignancy of the gastrointestinal tract, prepared by Prof. Sharaf. This is the appearance of an anastomotic recurrence. There is irregular nerving, irregular structure at this region with some protruding leakage, and there is definitely soft tissue mass indenting the region, anastomotic recurrent tumor along the colon. This is the sigmoid with a lot of serosal metastasis coming from cancer stomach down. Sigmoid with irregular outline denoting subserosal lesions in case of breast carcinoma. Here the transverse colon, as you see, there is soft tissue here narrowing the lumen of the stomach and is indenting the colon with marked coarseness of the mucosa. It is invasive gastric carcinoma. Here is a colon with carcinoma invading the stomach, and here is colon invading cancer colon, also invading the stomach at this region. This one is that one. This is the colon, this is the very minima, and this is the stomach. Here we have pancreatic carcinoma invading the colon. There is definite mass, there is definite narrowing, irregularity of this segment. Here there is stretching and elevation of the sigmoid colon with irregular outline and definite attenuation of its lumen, denoting a large pelvic mass. It is a malignant fibroid. Here is annular carcinoma filling this area, invasion by prostatic carcinoma. The rectosigmoid is invaded by a large prostatic carcinoma extension into the pelvic wall. Another case of narrowing of the rectosigmoid. This is the sacrum and this is the rectosigmoid. It's narrowed due to large prostatic carcinoma invading. This is the duodenum, and this is what we call inverted stree, and this inverted stree is invaded, irregular, with soft tissue indentations along the whole length due to renal cell carcinoma. Here the colon, the sigmoid, the splenic flexure is invaded by renal cell carcinoma. An ovarian tumor can produce irregular subserosal deposits causing irregular lumen of the small intestinal loops at the pelvis. A gastric tumor can do the same, multiple subserosal tumors indenting the small intestinal loops from outside. It is subserosal. And here is pancreatic carcinoma invading the region of the duodenum and causing a lot of multiple subserosal deposits involving almost the whole sigmoid region. seedling along the mesentery. These three represent seedling along the mesentery. Pelvic disease, metastatic seedling involving the sigmoid from anterior and from behind. 1, 2, 3 are in small intestinal loops invaded from outside, denoting multiple subserosal mesenteric mets. Again, the stomach and small intestine, as well as here in the pelvis, sigmoid. Melanoma can give subserosal deposits to stomach, small intestine, and colon, causing irregular outline, narrowing of the lumen, definite limited capacity, and thickening. Gastric, intestinal, and colonic mets from breast carcinoma. This is gastric subserosal deposits, resulting in an appearance similar to Linnitis plastica. So Linnitis plastica is not necessarily to be from inside as gastric carcinoma, but could be due to subserosal deposits invading the wall. Subserosal deposits invading the colon. Subserosal deposits invading the colon, causing irregular segments of narrowing, scattered along the whole length of the colon, similar appearance, and here at the gastroduodenal region. Gastroduodenal subserosal deposits. Of course, the small intestine are also involved. Now, sometimes we can get a tumor of one of the intestinal loops and then extension outside. This is called extramural extension of malignancy. Extramural extension of the malignant process. And here we have this bilharzal or attenuated inner rectal region, and we talked before about erection or erected inner rectal region, which could be due to pericolonic fibrosis or pericolonic masses, and here in this case it is due to multiple rectal subserosal deposits from breast carcinoma. Now for this one, you can see that the esophagus itself is replaced by a mass, so it is local. Then it extends to invade the mediastinum, so it is with direct extension. So it passed the wall and went outside. So long it is not confined to the lumen, it passes the wall and it extends outside with this irregular outline. This denote a T3 cancer. Now here, this is not only esophagus, it's also the esophagus is invading the bronchus. So here we have invasion of the nearby structure. So it comes from the lumen, fills the lumen, then extends along the wall, then gives very lesional regular outline, and then invades the nearby structures or direct extension. So this is T4. Now here is gastric carcinoma extending along the lumen, and if we can, I think there is no evidence of, no, there is extraluminal small protrusions here, extraluminal small protrusions that denote that this tumor is past the lumen, past the wall, and extends outward, so it is a T3 carcinoma. Now here we talked about such an appearance before when we said that this could be metastasis. These are metastasis, subcapsular, and here falciform, and here subcapsular, and here are seedling metastasis. So we have a lot of appearances. You can see the metastasis here and there, and in him here also, and in the falciform ligament. But this appearance, please try to remember the subcapsular hematoma of the kidney, and try to remember radiation hepatitis may result in such an appearance. Thank you.